Well, good morning. I'm Dr. Farrell Tyson, and today I'm going to be talking to you about the AL-Scan and how it really works for office efficiency and also the accuracy. Little disclosures, I do work with NIDEK and Marco. So what is this? You know, here's a device that in 10 seconds is able to get you an axial length measurement, the keratometry, anterior chamber depth, central corneal thickness, white to white, and pupillometry. 10 seconds. That's pretty dang quick. You know, we're used to having the different devices where a lot of this in the past, we had to use a keratometer for one device, we'd have to move the patient, get the axial length on another, then if we wanted to, we were optically trying to get an anterior chamber depth. Usually we didn't even bother with the central corneal thickness because we didn't know what to do with it. Now, the demands of our patients, especially in post-LASIK, are making this more and more important. White to white we were doing manually, and pupillometry, we were sitting in the lane with a pin light. As you've watched the machines in ophthalmology get better and better, a lot of this has been automated into other systems. Now you're getting this all in one, and it's all in the machine that you want it to be in. Because it doesn't matter if one machine does 2 or 3, but you still need this other machine over here to get the other parts. You want it all in the right machine. And that's why when I've seen some of the competitors come out, they're able to do a couple other things that you see on here, but I really don't need that to be able to do my standard cataract surgery, and especially my IOL calculations. On the other hand, this device has all the stuff that I need in one unit to get an excellent result. And also, what can you do in 10 seconds? You know, this really kind of comes down to, if you look at what the competition's able to do and can't do, they're using a lot of just smoke and mirrors, a lot of hype, and that kind of goes to here. I kind of think of the NIDEK AL-Scan as the Tesla P85D in the market. So, a lot of technology. Here's your competition. It's giving you all this smoke. It's all raw, big guns. It's a 700 horsepower Hellcat that's supposed to be the behemoth in the market. It gets up to the line. Once again, flash, dance. But when it really comes down to it, what really matters is who finishes across the finish line first. Having the better technology and being able to implement it makes all the difference in the world. Yet the competition is going to try to sit there and say, I'm the 100-pound gorilla in the market, you need to be with me. But in the end, you want the device that's going to be able to give you the most accurate information, the one that's going to be able to do it in the quickest time, so you use less staffing. So how do we talk about staffing time? I'm lucky or unlucky enough to have multiple offices with multiple different devices. So I've got 2 IOL masters, I've got a LensStar and a satellite, and then we brought in the NIDEK AL-Scan. And my staff was going, oh gosh, why are you bringing in another different device? Is this really going to make sense? Now we're going to have to learn a new one. After the first day, they're like, we like this. After the second, first month, they come back and go, we are keeping this, aren't we? Is there any way that we can go ahead and replace the other ones? Because it only takes 30 seconds to do both eyes. The patient, you sit them down, you're able to go in, bam, bam, and usually that would just be to get the axial length on my IOL master. We've already gotten all the readings and the results. We're already now printing out our lens selection. So if you look at the IOL Master 500, we thought that was a big increase from the 5, but it takes about 1 minute 39 seconds to take the readings. It's 3 times slower. And this is, when we timed it, this was using my eye. I don't really have much of a cataract. It's a pretty easy eye to shoot through, but it was 3 times slower. The LensStar, my staff doesn't even want to work on because it is so cumbersome in the exam lane to do. It takes over 3 minutes to get the patient through there if they are cooperative. So this examination time really makes a difference. Why? 1, you can see more patients. In a busy ophthalmology clinic, you need to move the numbers through. You have to have them coming through. 2, I'm able to employ lesser paid staff. I don't have to have my super tech sideline doing axial length measurements. I can use my lowest paid staff to be able to take these measurements because of the simplicity of use and the error correcting that's involved. So by both of those, it's allowing me to see more patients, it's allowing me to better utilize my higher paid staff, and therefore it's very much a cost saving to my clinic. Also, this is not a standalone device unless you want it to be. It also has integration with the rest of the surgical suite. It'll tie in with your NIDEK OPD3. That allows you to do autorefraction, wavefront analysis, corneal topography, pupillometry, and keratometry, and also with NIDEK cell counter. So now you have a whole surgical suite of instruments here. I think this makes it a lot easier, and this is how mine is set up. I've got the OPD3 on one side of the stand, I've got the AL-Scan on the other. As you can see, they're very similar devices from an aesthetics point of view, but they're very similar in their ease of use. So it's not having to retrain and relearn, it has the same basic usability for your staff. What I enjoy in my practice is I can do this all in one day. When I go around and I speak, I do a lot of consulting for other companies, but also practice management. And when we're talking about how we run our practices, a lot of it is centered around premium IOLs. And it was, well, how do you get such a good conversion rate? Well, one is I have a directed discussion. How do you have a directed discussion? Well, you better have the information from your NIDEK OPD and your AL-Scan before you walk in the room. Most people look at it the other way around. They say, well, I'm going to go in there, I'm going to talk with the patient, and I'm going to say, oh, Mrs. Smith, you have a cataract. Now, there are a lot of different lens options out there, but I actually don't know which lens option would be good for you because I have no data on you. So I'm going to have you come back on a separate day for biometry, and I'm going to have somebody else talk to you about the lens choices. That does not work in a clinic because, one, they trust you more. They want you to be able to help make a decision and choose that, help choose that lens for them. Also, bringing the patient back is a hindrance to them, and it's costing you staff time because now you have to pay staff to check them in, check them out, make the recall call to make sure that they're coming in, they don't miss their account. You want to make sure this is all done beforehand. So in my clinic, we kind of know who are good patients that are probably going to have cataract surgery. Our equipment is so fast and gives us so much information that I can go ahead and have the patients scan on both of these instruments prior to walking in the room. And so at that point, I can take the slit lamp, look at the patient, say, you know, Mrs. Smith, I see that you have cataracts. This is a wonderful opportunity for you. If you see here on this OPD scan here, you can see that you have astigmatism. Some of these multifocal premium lenses that you hear about that are supposed to give you distance and near, you're not really a good candidate for it. You're a better candidate for a toric IOL. Oh, okay. There's two different toric IOLs that we use. One's accommodating, one is not. I can now circle on my AL-Scan printout the lens choices that I think would be good options. I walk the patient over, I make the recommendation to my surgery counselor with the patient right then and there, and my surgery counselor can look at the printout of the AL-Scan and they can say, okay, these are the lens choices that Dr. Tyson has approved. We can work from the top down and see which lenses the patient would be most interested for their lifestyle and their financial status to be able to do it. So I think running this type of equipment with this speed and having that available to you allows you to have that 60–70% conversion rate of going to the premium IOLs. So this is just another way that your technology, even though it may not have in the OPD's case a CPT code for it, these machines more than pay for themselves just by the ability to be able to better upsell the technology to your patients. But what good is it if it isn't getting you the right information? You want to have that accuracy and reproducibility. Well, the IOL Master and the LensR, they take multiple scans, just like the AL scanner does, but it averages. Well, garbage in equals garbage out. So if you're averaging and your techs aren't smart enough to say, this one just doesn't make sense, even though it's highlighted in red, they need to delete that out and manually delete it out to get you a good average. The AL scan does it a different way. It says, okay, I'm going to take a series of readings and I'm going to analyze them and I'm going to find the one that has the best signal to noise ratio, which means it's the one that's going to be the most accurate one, that it's the best centered, the best reading, and it says, we're going to go with that. The other nice thing is it's using an 830 nanometer super luminous diode. That's a lot, that's a mouthful. Say, okay, I wasn't able to get it, I'm going to go use my immersion. Now I got to take the patient out of there, I got to take them into another lane, I got to lay them back, I get the water out, and the next thing you know, yes, you get a good result with your immersion, but it's a 15, maybe 20-minute ordeal in total getting the patient over there. So it's great having a bright light source that's able to go through. Then this comes to keratometry. How many of y'all have heard the rumor that certain lenses have an IOL master A constant and an ultrasound immersion A constant? It doesn't matter. The machines are going to measure the same axial length. The difference is the keratometer. So if I take an ultrasound measurement, my axial length should be the same as my IOL master or the lens star or the AL-Scan, because even though they're measuring slightly different lengths, the IOL master, since its beginning, always had a little fudge factor in there so it would match, quote, the gold standard of immersion ultrasound. The difference is that you get different results is because if you're using an immersion ultrasound, you're probably not using your keratometer off of your axial length measurements. Now, we start getting into it. When I first came into the practice, the senior partner had bought an IOL master, and it was sitting in the corner. And I go, why are you sitting this in the corner? It's a very nice device. He goes, the Ks don't match with our manual keratometer. And I go, yeah, let me take a look. And I look into it and found out, well, first off, it's measuring only 6 points at 2 millimeters. Your manual keratometer is out around 3 millimeters. In addition, the IOL master uses a different refractive index for its corneal indice than the keratometer, and at the time we were using a hog stripe block type keratometer, which used an even different corneal refractive indice. So you have to make sure that you understand, are you measuring apples to apples or apples to oranges? The other thing is, IOL master, all it cares about is average K. That's why it only has 6 points. It really doesn't care about axis because none of our IOL formulas care about axis. Do they care about the magnitude of astigmatism? No, they don't. All the formulas care about is the average keratometry and axial length. When you get to 4th generation formulas, now they start asking for anterior chamber depth, white to white, and other things. So the IOL master was made just to calculate IOLs, not to do refractive cataract surgery. The lens star said, well, we realize that there are some limitations here. We're going to go with 2 different rings now, and we're going to bump them up to 16 points, but we're going to measure at 1.65 and 2.3, so it's going to give us a grand total of 32 points. So at least now we're getting a little bit better accuracy if you're wanting to look at axis and magnitude, but are my keratometry readings going to match? Well, this one's at 2 millimeters, this one's at 1.65, this is at 2.3. They're going to be close, but they're not going to be the same. The other thing that you're going to have to worry about here is you still need to have your OPD3 because any of these machines are going to still look at maximum and minimums. If you have irregular astigmatism, it's going to come up with an average and kind of give you Ks that don't necessarily make sense to you. The average is still correct, but the magnitude and the axis may be wrong. So you want to have that OPD scan to see, is this symmetrical astigmatism that I'm working with? Is this where I want to put my toric IOL? And is this where I might want to put femto LRIs? So when the AL scan came out, they said, look, we're going to do it one better. We're going to measure at 2.4, 3.3. We're going to go with 360 points for a total of 720. And we're going to let the user decide which set of points we want to use in our calculations. Then, NIDEK understands all us surgeons, we're all different. And we all think that one thing's a little bit more important than the other, so they give us choices. They allow us to come in here and take the measurements, but we can actually go in here and make some adjustments. So, lens status, of course, most of the time we're going to be doing phakic eyes, but sometimes we need aphakic, pseudophakic, silicone oil. The other machines can do that too, but it's built right in, it's very easy to access. This is kind of interesting, an ultrasound offset. So let's say you have one brand of ultrasound and you keep finding your axial lengths don't match up. This is great that you can kind of go in here and go ahead and adjust the offset so this axial length will always match your immersion axial length. Now what you have to understand now is that you better be optimizing your lens constants because by putting that offset in there, you're going to want to be able to optimize so your A constants shift back so they match up. Your keratometry here, you can have your choice. Do you want to go with the 2.4? Do you want to go for the 3.3? And this can be used in certain different corneal things. What we find is most people are going to use the 2.4 because it better matches the other devices that we're used to seeing. Then we get into IOL calculation. This once again goes to choice again. We have multiple lens formulas to choose from. In the past, when we wanted to have a printout or a visualization, we had the choice of saying, okay, either I'm going to pick one formula and it's going to show 4 lenses, or you were going to pick one lens and we'll get 4 formulas. Here I can go through and I can say, okay, well, I want to use this lens, let's say a crystal lens. The company tells me I'm supposed to be using SRKT. I'm going to use SRKT here. On the other hand, I can say there are other ones. I have mostly Northern European blonde hair, blue-eyed population, which are hyperopes. The Hoffer Q may be the better choice. So on my other standard lenses, I want to use the Hoffer Q. So I'm able to pick and choose how I want this printed out, or I may want more information. I want it all left eye information, or maybe I want a pair where I want some right, some left. So this really allows you to set it up on how you want to see it in your clinic. Then we get to optimization. This is probably one of the things that really gets overlooked. Most people think that these devices are point and click. Well, they are to a certain extent, but if you really want to have excellent results, and now the lens technology is out there, it used to be, if I was good at distance, that was pretty good. Then, if I'm off a foot at 20 feet away, the patient's still happy. But now we're into multifocal lenses. I've got 2 focus points. If I'm off a foot on the near focus point, the patient's extremely unhappy. Now we're into enhancements. So you really want to get into optimization. And in the past, you had to really be picky about what cases you're putting in. NIDEK has done a nice job of allowing us to come in here and say, you know, I only want to deal with the eyes that had post-operative results that were good. I didn't want some of these weird outliers or macular degeneration patients that couldn't see very well on the eye chart, and maybe it wasn't the ideal eye to be in here. I can also pick how far out that post-op data is going to be. I don't want to have any 1-week, 2-week readings being averaged into my optimization. I want it to at least be a month or so out. Then when you see here is, you can go in here and it actually tells me how many numbers of eyes are actually been put into this optimization. Usually you're going to want to have about 25 or more, and you can keep updating this. But once you get about 25 or more, that should be it. One of the things that I ran into with my original IOL master was when the Technis monofocal came out, I was like, oh, this is going to be great. Went in, did my calculations, and I was using the Hygas formula. Put in about 25 eyes that day, came back the next day, and I had 4 myopic surprises at -2. Like, what's going on here? Went back, reran the calculations using Hoffer Q, Holiday, and SRKT. They all gave me the right answer. The Hygas was giving me the wrong one. What's the difference? The Hygas uses the anterior chamber depth. And if your anterior chamber depth is not highly reproducible, you get surprises. Luckily, I was able to do the other eyes. Those were second eyes, and those patients turned out to be wonderful monovision, but it could have been hyperopic surprise the other direction, and it would have been awful. So I've been very hesitant to do the Hygas, and when I looked into it more, I realized that the optimizations in the other devices, they only optimize the A0 constant. So what that means is normally when you're optimizing, if you have a graph with a certain slope, usually you're just moving the slope up or down. The beauty of the Hygas is it's supposed to be able to bend and twist and move up and down. So at the extremes, you want to be able to adjust them as much as you adjust the middle of the curve. And that's why you have the A1 and the A2 variables. But on the IOL Master, you were not able to do this unless you wanted to go into an Excel spreadsheet and put in at least 50 eyes. So it's nice that this device automatically goes in there and does the optimization on A1 and A2, because the Hygas formula is very powerful if it's optimized correctly. So here's when you see the different formulas, you wonder, well, if I've got 5 or 6 different formulas, nobody must be right. No, it's just that they're looking at different things. So if you look at the normal axial length eye, usually the Holiday is going to cover pretty good from normal to long. Hoffer Q is good from your really short eyes to normal eyes. Then the SRKT has always been better for long eyes. And the Hygas is supposedly supposed to be a mathematical formula that's able to cover from one extreme to the other. The Holiday 2 works a little bit differently. The Holiday 2 is doing pattern matching. It's saying, well, if I've got a white to white of this, and I have an axial length of that, and the keratometry is this, it falls into this bucket, and we're going to come up with this type of power. So it's getting to it a little bit differently. These are more mathematical. This is more kind of, in the grand scheme of things, a pattern matching. So let's say we're going to go ahead and optimize. Well, I'm going to take normal eyes, I'm going to put them into the system, and I'm going to tell the computer to optimize. Well, what happens? Well, the Holiday 2 optimizes to normal. The Hoffer Q optimizes to normal, the SRKT does, and the Hygas does also. So now, after you've optimized, you're sitting here going, well, what happens for my long eyes? I normally would use an SRKT, now I'm less accurate. It's because what are you optimizing here? So you need to kind of start looking at it and say, okay, I really need to look at optimizing my holiday for the normal eyes. So I want a holiday optimized with normalize as the data. I want to take short eyes and I want to optimize that data set for the Hoffer Q. And then I want to take large eyes and optimize them for the SRKT. Then the HIGIS, if I'm just optimizing the AO, I'm going to end up in the middle, but if I optimize it using all of my data, it'll optimize the A1 and the A2 constants and pick up the extremes. And that's why the Holiday 2 is very popular, is because it's not requiring all this optimization, but you need to make sure you understand what are you optimizing, what are you putting into the system. And this is where you start getting into having different IOL formulas for different axial lengths, and that's why you might want to use them that way. In studies, you start seeing out there, Journal of Ophthalmology back in 2014, they wanted to see, is it reproducible? When I used to talk about the IOL master, everybody goes, well, do you trust their Ks? I go, no, I don't believe they're accurate Ks, but they were reproducible Ks, and since I was going to optimize my IOL constant, it was going to take that reproducibility and shift it into the zone where I could achieve my accuracy. So repeatability was very important, especially with IOL calculations. And what they found was the correlation coefficient was 0.996. 1 is perfect. So this was using multiple users and multiple patients, and they found that the reproducibility between the different groups was pretty much dead on. What that tells me is I can use different technicians. I don't have to have a designated A-scan technician. I can use different technicians, and I'm going to get the same repeatability of my measurements. The other thing is, well, how does the AL-Scan versus the IOL master work? Well, we looked at R values to see how they correlate. They used a 2.4. Remember, the IOL master is at a 2. Even with that little bit of difference, we found that the axial lengths were almost dead on, and when they were looking at calculations with the SRKT formula, they were dead on. So it should match up very well. What did I find in my clinic going from IOL master to SRKT? When I optimized, I was probably about 0.15 diopters difference on what I was hitting. And so I think when you get this, if you use your regular your regular optimization values, it's a great starting point, but once again, after about 25 eyes, I think it's worthwhile to go ahead and re-optimize on the AL-Scan. It'll make you more accurate. So what I find here is really, when I brought in the AL-Scan for me, I was very impressed with the ease of use. I was not expecting it to be so popular with my staff. I expected it to be accurate. You can't sell a device if it's not accurate for picking lenses. But when it was coming to having my staff utilize it, the patient flow, it really makes a difference. Because my patient base, these are the 70, 80, 90-year-olds. I don't need them trying to sit there and struggle for 3, 4 minutes to get the job done. I can do this in 30 seconds. I get highly accurate results. It